get back to our main topic now that hosted the news all around the world, of course, during the past year, COVID-19. Let's go behind the scenes to see how different hospitals handled the pandemic worldwide. And let's first head to South Africa to see Mervyn Meyer. Mervyn is with us. You are the principal specialist at the Charlotte Maxeke Johannesburg Academic Hospital. First of all, Mervyn, what happened in your IC unit during COVID? Tell us.
Thank you very much. And before beginning, I'd just like to pay humble and very significant homage and tribute to all the absolutely courageous heroes and healthcare workers around the globe. I think everyone has done an absolutely remarkable job. But in South Africa, which is a resource-limited country, a low middle income class country, we soon recognized that in fact, unless we really prepared adequately, we may very well land up being in big trouble in terms of how to deal with the problem. So preparation was absolutely paramount, and we had 3 or 4 months of time versus elsewhere in the world to prepare adequately. And one of the things that we recognized, bearing in mind we only have around about 35 to 45 functional practicing intensive care specialists in the whole country, for a country of 60 million people, was that COVID, despite the challenge, also brings opportunity. And I think that was a very important issue. And so within very little time, following the preparation and appropriate communication, we recognized we had to expand our existing facilities, not necessarily to create field hospitals, but to maximize what we had in-house. And so within 6 weeks in my own hospital, which was designated a major COVID referral center, we in fact had more than doubled, effectively trebled our ICU capacity. We hired staff, we started nursing upskill programs, and to cut a long story short, we were able to manage where at one point in time, we were the 4th or 5th most afflicted country in the world, everything that we in fact had. It was not easy. And in fact, one of the things that I have to emphasize is that being poor doesn't mean poor care. In fact, excellent and sound practice with good quality care is possible. And what we aimed to do was maximize the simplicity and the principles of care so that we could get things correct most of the time. And in fact, many of the outcomes were very, very favorable. At the outset, we didn't have what everyone else had, ventilators and high-flow nasal oxygen devices, but we maximized, we utilized, and in fact, we improvised with creativity and innovation, and eventually many of those entities prevailed, and we were actually able to confer what I believe was really excellent care in the face of potential adversity, and we've always endeavored and aimed and aspired for excellence with passion and with purpose, and it comes with a spirit that can only be recognized in a developing country and in a continent such as which I practice in Africa, where we went about things with the spirit of Ubuntu, which means to actually go about and practice care with compassion and with humane elements associated with it. So at the present moment, we in fact have an expanded facility. We've probably advanced intensive care 10 to 20 years ahead of where the wheel would have turned, with the recognition that in fact we had to do that. And so as our surge has decreased a little and we're waiting for our second surge, we're in the midst of summer at the present moment, and numbers are starting to build up again. In my own hospital at a point in time, just to share the elements, we had packed ICU, 450 to 500 patients within the hospital. South Africa, in fact, has had around about 21,500 deaths and about 800,000 individuals who've been affected, which is probably a gross underestimate because we don't have the same testing capacity. But we were 4th or the 5th most afflicted country in the world at one point in time. But I think the important legacy that will be left is that we've been able to maximize, expand services, start nursing upskill programs, bring intensive care to the fore, because it would not have been possible without intensive care. And I can tell you right now as we speak, hundreds, if not thousands of non-COVID lives have been saved because we've had expanded facilities where patients would not necessarily have had the option of intensive care therapy, or even the option of going to an intensive care unit. And so maternal mortalities have been obviated. Big cancer surgery has been allowed to actually happen. Trauma has been dealt with, and many other complex medical cases where individuals would not necessarily have had the possibility. And very lastly, just to share what we did do in a simple fashion, because if you do the simple things well, most of the time you will have a successful outcome. What we were able to do, and we're just busy analyzing some of that data, where after all this preparation, appropriate communication, sorting out our own PPE issues, we were actually able to, I think, deliver care of excellence in a simplistic fashion, doing all the correct things. I'd like to believe in the correct way. There's only one way to do things. That's the correct way. And in fact, the outcomes in many instances look as good, if not better, than many of our first world counterparts. So I believe it is feasible, it is possible to achieve that excellence, even in the face of adversity. And once again, just to reiterate, being poor doesn't mean poor care. You can strive for excellence in the context of things. And once again, the enthusiasm, the passion, and the way that people went about things has just been absolutely remarkable. We're waiting for our second surge. I've just come down from the ICU now, and in fact, the numbers are increasing, but not nearly at the same degree that is happening in Europe and perhaps elsewhere in the world. But that may well happen come the next month or two. But I think we're in a far better position than where we were right at the outset. And I think, as I mentioned, perhaps the most important element that's come out of this is that opportunity has been taken in the face of real adversity. So nothing, to finish off with, nothing is impossible. I like to turn it around. Impossible is sometimes nothing. Leave you with that.
Thank you very much, Mervyn. Thank you very much for giving us some of your precious time. It's been really great to hear from you today. Let's head to the USA now to hear from Heatherly Bailey, emergency medicine intensivist at the Durham VA Medical Center. Heatherly, good to see you. How did COVID transform your emergency department? Tell us.
Well, thank you for the invitation to attend, and I would agree. I'd like to express, just like Mervyn did, my admiration for our colleagues around the world in both critical care, emergency medicine, pre-hospital, and the scientists that are working so hard to bring us a vaccine so that we can hopefully bring this pandemic to a closure. It's been challenging, just like everyone else. We had some forewarning, thanks to Maurizio and his information from Italy, that we were able to prepare our hospital. But what we quickly realized in the beginning of March was that we didn't have enough supplies. Our PPE was limited, so we had to restrict the number of masks. You were limited to 1 mask a day. The gowns, or disposable gowns, were in very short supply. So we have limited disposable gowns to aerosolizing procedures. And we have these laundered gowns that our laundry is doing a phenomenal job in turning over hundreds of gowns every day to refill our supply. We had only a handful of negative pressure rooms in our ICUs and in the emergency department. And so they were able to procure portable HEPA filters. And they have been brought down into the room so that if there is a COVID patient, they're in the hallways, they're in the rooms. And so we've managed, and we did have a little bit of a lull in my area during the summer, but unfortunately, as you've probably heard, the United States has been leading this pandemic unfortunately in the numbers and in deaths. And our numbers in the country have been increasing every day for the last, I think we're on the 18th or 19th day of steady increasing. And we've actually had more than 1 million patients in the last, people ill in the last 6 days. And one of the challenges we're facing now is that we've had so many staff that have contracted COVID, both from in work and in their daily lives. You know, just going to the grocery store, as you know, is not a safe thing, even though you're masked and doing your best to stay safe. So one of our big challenges right now is staffing making sure that we have adequate people to care for our critically ill patients. We've had to close sections and we've all had to work harder. I just worked last night and I left several hours later than I was supposed to, just because of the need for help in the system. But I think that we as a team are really have come together. We really try and watch out for each other. If we see that someone is a little bit tired and maybe is not appropriately donned and doffed, we watch out to make sure, especially our house staff that change out a lot, they really I think have been a bit challenged with both their education, because it's been so different. But I think that our level of care has increased, as Mervyn has said, and I think that we are all grateful that we see a potential end with the vaccines that will hopefully make a difference and allow us to be able to go back to some semblance of normal, but maintaining a vigilance. So thank you for the time.
And thank you for your witnessing today. Thank you very much for being with us, Heatherly. Let's now move to South America, to Argentina, to see Elisa Estensoro, Director of the Medical Intensive Care Unit at the Hospital Interzonal General de Agudas, General San Martín de la Planta in Buenos Aires, Argentina. I think all the Argentinians that are watching us are laughing at me with my accent, but Elisa, we're really thrilled to have you with us today. Thanks for being here. What does your working environment look like these days, Elisa?
Well, thank you very much for the invitation, first of all. But I must say that really we had an advantage in time, because we were able to see what happened, to witness what happened in Europe and different parts of the world, because before the pandemic came to Latin America, Argentina in particular. So we had a lot of time to prepare. Think of this, in March the 20th, lockdown was established. And during that time span, the government in general acquired lots of equipment, ventilators, monitors, personal equipment, and also many health personnel entered into the system, especially into the ICU. But the problem was that there were no many intensivists. We have new nurses, new therapists, but not intensivists, because, as you know, well, this specialty is not chosen by young doctors, and especially in Latin America, in which the wages are so low. So it was quite a problem. But really, during the months of March, April, and May, in our hospital, there was big preparation, educational activities, and also the ICU became the center of learning activities for the rest of the hospital. But what happened in Argentina with this very early lockdown was that the cases really didn't seem to arrive. Really the peak of cases, we had it at last in the third week of September. So during all the time, we are preparing for a battle that never arrived, never seemed to arrive, until finally, during the last month of August, the cases started to rise. And of course, we were not overwhelmed, luckily. We were highly stressed. And what happened to the personnel, we were really committed and focused on this, but they began falling sick. And really, we did not have many replacements for them. So we had what we had, and the work really doubled. Not only because of the doubling of the number of beds, but also because we had to replace those who came down with the disease. And in Argentina, there was another particular that also happens in Colombia, that we had no peak of cases. We had a very long-standing plateau of cases, and that really produced people got tired and discontent. And also the same happened in the society, because the lockdown was established in March, but really after that, it was relaxed, and people were pushed from a releasing of activities. And when we came to the peak of cases in September, the highest part of the plateau, really society was tired and didn't want to hear anything about being in lockdown again, or just to they were pushing for new activities, So we have this feeling of an extreme work and stress in the ICU with very sick patients. I know most of them being prone and with all the work that entails, and the society that was looking to something completely different. So, well, there were different times. As I told you, many got sick, but really they're all with us, at least in our hospital. And now cases began to decrease. We are in 50% of cases in our COVID unit, and really this is diminishing. And we are looking forward to the summer, But we are still with 8,000 cases in Argentina per day. So it's still a number which should be decreased, because we are entering the summer, and while people now are in the streets, they are not taking the precautions. We are not seeing isolation or distance anymore, unfortunately. So we are afraid what can happen during the next autumn. But there's great expectations about vaccination here. So we hope that maybe the second wave will not be so, I would say, intense and deadly as the first.
Thank you so much for being with us today. It was wonderful to have you. Let's move on now to Asia to see Kent Doi in Japan. You are a professor at the University of Tokyo, Kent. You are also one of the executive directors of JSICM. Tell us what happened in your IC unit.
Thank you very much for inviting me this very nice conference. And right now, we Japanese are facing the third wave of the COVID-19. In the first wave, we took care of the relatively younger patient, and in the second wave, many patients who is around 20 years old or so, very young patient, became positive for COVID-19. But at that time, we don't have so many severely ill patients. But right now, in the third wave, many old-aged patients were becoming positive for new coronavirus and needed for intensive care in my ICU also. So currently, around 20,000 of the Japanese patients were treated in Japanese hospital, and 500 patients required intensive care in ICU. So what I want to say is the patient background is being changed from the first wave to the third wave. So in the first and second wave, we didn't have to worry about so much about the capacity of our ICU. However, right now we are so much worried about our ICU capacity, not only for the space, but also the number of the medical staff. So unfortunately, we don't have so many intensivists here in Japan, and the intensivist is not a so popular subspecialty. So that's our very big problem. So we need to think about it, and we need to, expand our educational program and to increase the number of the medical staff who can handle with mechanical ventilation and maybe the treatment with ECMO. That's our current situation in Japan.
Thank you so much for being with us, Kent Doi. Do you have any comments, guys, on the set from what you've heard from this world tour of the different hospitals and our friends that have been kindly with us today?
Well, I think one of the important things we hear from them is what we have also experienced, the unexpectedness, the surprise, and big numbers of patients coming suddenly. I think that aspect is very recognizable, and Mervyn has indicated very well the situation in low and middle income countries, but actually what I wanted to add to that is that in this COVID-19 crisis there are no rich countries, because all the rich countries, so-called, we all felt the lack of facilities,
Yes.
the lack of beds, the lack of personnel, the lack of equipment and materials. So that, I mean, it's not a good way of uniting each other, but this has, in one way, is quite uniform for us all, which we have experienced.
Yeah, and I agree. Thanks for sharing your experience. And it's also the key message, I think, is everywhere in the world. It's not about space and technology. It's medical personnel is clearly our biggest resource, and it's not so easy to find them in a short period of time. So I agree. We hope in vaccines and what the citizens can do to keep the contagion down.
Would you like to say a word on
Yeah, yes, what I like very much is we hear many similarities between the countries. I was a little bit amazed also by what Mervyn told, that the non-COVID care was better possible than before the COVID crisis. And I think you are probably much better in improvising than we were in the so-called rich countries. So that was perhaps an advantage. But I also want to emphasize the enormous stress it gave on the personnel. As Hadley said, that some of your colleagues get ill. We ourselves, we had also in our unit, there was one of our previous nurses got really very ill and even died because of COVID. And this has, of course, a very big impact on your colleagues in your unit. And the big difference for me was as a crisis that you have a crisis in the hospital and where you work, and that is part of our normal work. But then you go home and then the crisis just goes on. And I compared it to that you hear all the time the sound of the Jaws movie, you're sitting there and it's always a threatening sound going through your head. And I was very interesting to hear your experience about it in the different countries and continents.
Thank you so much to all of you for this world tour of your different ICUs.